Okay, so if you're ever on Zoom, gotta have your camera on. I do need an email from you that you need to and ask permission for you to attend via Zoom. I do try to record class sometimes. Don't feel bad if you don't think I'm recording, raise your hand. I'll record the important pieces. Okay, let's talk about gas exchange. Tell me what you already know. Fundamentally, what is gas exchange? Patho, nuts and bolts, nitty gritty. What are we talking about? Right, so we breathe in oxygen, right? Goes down to our lungs, to our alveoli, and we exchange CO2 for O2, right? And we breathe out CO2. So what's the first thing we do if a patient can't breathe? Yeah, raise the head of the bed. Put some oxygen on them. Check their airway. So, does it change whether you've got somebody with pneumonia, TB, any of those things? No, gas exchange is gas exchange. This is the beauty of teaching concept based. We're just going to add pulmonary embolism and cystic fibrosis. Lifespan. Are you going to see kiddos with cystic fibrosis? How many of y'all like kids? I almost became a PD nurse. PDI and CCU were the only two I liked. And now I'm like, oh my God, PD? Really? It's only, I had a lot that I didn't like. And then I found my niche. And so people switch all the time. It's the same concepts. Okay, so number one, I put big stars and I'd write this down. This is important information that you're going to need that I'm going to refer to all the time. The first thing is I'm going to introduce you to the MAP, mean arterial pressure. It should be greater than 65. If our MAP is less than 65, we are not perfusing our vital organs. If I don't perfuse well, where does blood get shunted? To my brain, to my heart. So guess which organ didn't get any? That's always testing. Your kidneys. We deal with a lot of acute kidney injury. You've had chronic renal failure. We're going to talk about acute kidney injury. Renal failures, renal failures, renal failure. This is an acute thing. So MAP, normal, 65. Normal is really 70 to 100, but as long as we are 65 or higher, most of these things will make way more sense when we get to the shock content in module 2. But we talk about it all the time. My mom was just on 3C in July with sepsis. And they came to take vitals, and I looked on the machine and it says, if the MAP is less than 65, please contact the charge nurse. I'm like, that's cute. Then I went to the manager, who was actually my old boss at Northwest. I've known her forever. And I'm like, oh, I see that. She's like, oh, yeah, it's the sepsis criteria. And I'm like, of course it is. Okay. So the example is 120/80. Your MAP is 93. Diastolic times 2 plus systolic divided by 3. I will give you the MAP. It should be what? 65 or higher. When I ask you what a MAP should be, it should be 65 or higher. If not, we are not perfusing vital organs. Those organs are going to suffer. Your patient's going to go in some kind of shock and die. Now, can it be higher? What if it's 140? What does that tell you? Don't make it hard. If less than 65 means my blood pressure is low, 80/40. So if my MAP's 140, what's their blood pressure? It's super high. That's okay. You're shaking your head no. You're making a funny face. Thank you for that. Of course not. It means they're hypertensive. 200/120, not a good blood pressure. That patient's going to do what? Yeah, absolutely. And it may be people who've been walking around like that for years because they don't have access to healthcare and medications. It's all interrelated. So I'll give you a MAP. The answer should be what? 65 or higher. It'll make sense in shock. O2 sat. 95 or higher. Is there a patient population that might not be 95? COPD. What's the ABG values for people in COPD? Oh, look what I did there. What's the problem with COPD? When I think of ABGs, I have a pH, PaCO2, bicarb. PaO2 as well, but when I analyze COPD, what do they do? Oh, we got to study some ABGs. All right, I hear people over here talking. I just can't tell. What kind of allergies? Respiratory, because they retain PaCO2. CO2 is an acid. There's an ABG review for you. There's some audio files in there. There's a step-by-step way to do it. When I started teaching here, I'm like, oh, I recognize this from Northwest because I was the educator for a couple of years. They retain PaCO2. So they're in respiratory acidosis. They're not going to have a O2 sat of 95. It better be what? 88, okay? So let me tell you, an O2 sat of 90, your patient can have a PaO2 less than 60. That's considered hypoxemia. Normal PaO2 is 80 to 100. Not the same. PaO2, which is not the same as an O2 sat, SaO2. Nobody should have an O2 sat less than 90. Do we see significant emphysema, COPD, where patients may have O2 sats less than 90? Yes. You better have an order that says it is okay to have an O2 sat 88. If not, you were wrong. Something happens to that patient. You may be going to court over that. Nobody should have an O2 sat less than 90. Normal is 95. Now, if I have COVID, the flu, all kinds of stuff, might I have an O2 sat somewhere between 90 and 95? Yeah, I've had bronchitis 2 or 3 times. I've had COVID a couple of times. My O2 sat was still 92. I'm acutely ill, not showing signs of hypoxemia. That would be an expected finding. Should my O2 sat now be less than 95? Right now? Absolutely not. What's the most common reason people have COPD? Smoking. So they may have lower PaO2 and PaO2 and higher CO2s, but their O2 sat should be 90 or higher. Got it? If not, you need an order to cover you because you're gonna could go bad for you. Urine output 0.5 to 1 mils per kilo per hour. 70 kilos, that's the standard patient, which is never the standard patient anymore. So if you're like, well, 30 mils per hour is fine. 0.5 for a 70 kilo patient is actually 35 mils an hour. Do we put Foley's in people all the time? I see this and I saw this. You shouldn't. That may be the correct answer. Why are we not seeing as many Foley's? Yeah, infection. So what do we use a whole lot of? Yeah, PureWicks or whatever the thing is. My mom in the hospital with sepsis had a PureWick. Works pretty well. You need to know how to put it in. You got to put it in just right, not too much because it is under section. So we can measure that. If you're not measuring it hourly, I will tell you in the ICU, we are better now. There are still a lot of urinary catheter Foley's, but if we can use a PureWick or something along that line, a Quibi or whatever the trade name is for a male, we're going to do that. But it's important. Because if I'm not maintaining this, I'm not perfusing my kidneys. That will make sense when we get into acute kidney injury, okay? Easy math. If I weigh 80 kilos, half of 80 is 40. So 0.5 half to 1. So 40 to 80 an hour. There you go. 30 isn't it? And you can do the math of what that would be for your shift. What do you do every time you walk in a patient room? I have a lot of soapboxes. I'm going to stack them all up here and walk on. Every time you walk in the room. Yeah, you're looking at your patient, right? If they have a lot of tubes, lines, and drains, welcome to the ICU with the person with 7 chest tubes, an ICP, a ventric drain, all kinds of stuff. Shouldn't you put your eyeballs on those all the time? I had, I think it was a student or a former student who worked on the floor. So in the ICU, we're in the rooms all the time. Like we may be there for 2 hours and never come out. But they said what they did is they made sure that their tech took all of their Foleys and put them on the outside. So when she walked down the hall, she could see Foley, 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 Foley. Because if you walk in and you got this much urine at 8 and this much urine at 12 and this much urine at 4, you got a problem? Yeah. Should you have caught it before you got to 4 p.m.? 100%. So even if you don't have a urinary catheter, you can kind of say, this is what this output for this patient should be. Now, there's patients who don't. What patient population would not have much urine output? Do not make this hard. Yeah, somebody with renal failure on dialysis. They made my least favorite thing. This happened in real life. Sent a patient into surgery. They came back. They had a Foley that was like right out of the package. And I'm like, why'd y'all put a Foley in this patient? And they're like, well, they didn't have one. I'm like, they're on dialysis. And they're chronic. What did we just do for the patient? Yeah, risk for infection. It was dumb. Because when I have somebody who's chronic dialysis, my question was always like, do you make urine? Yeah, like I pee every 3 days. Cool. They don't need a Foley. Don't put, yeah. You're making faces. I'm going to have fun. Keep making faces. It makes me happy. Yeah, don't do, they just, everybody needs a Foley. No, they don't. And we're getting much better at that. But we have CAUTI and CLAPSI, central line and Foley. So we don't see as much. I will say we do use them a lot in the ICU. Okay. 10, 36 to 38. That is 96.8 to 100.4. That is part of the sepsis bundle. We will talk about that. I may only give you a Celsius 10, 36 to 38. That is normal. So I put big stars by this because this is information you're going to see all the time. It's not just, oh, I like new things. When we get to sepsis, you're going to understand all the shocks of why I use all these, okay? And when I saw that thing on the blood pressure thing on 3C that says if their MAP is less than 65, I was like, oh my God, I'm so excited because I've talked about it for years, okay? Concept map. Yeah, I looked at this. Here's your ABG values. The normal pH is 7.4. We use 7.35 to 7.45. When we do compensation, you need to be sure and look at that if you are struggling with that and go see Z. Because when you name it, 7.4 is your only one. We use 7.35 to 7.45 when we talk about compensation. What does compensation mean? It's the body trying to fix it or has fixed it. If I have somebody who has COPD and they've had it for years, what's their PaCO2? Yeah, it's high because they retain PaCO2. That's the problem. They suck in air all day long. What they can't do is push it out. What physiological changes do we see in their chest? Yeah, they have a barrel chest. What kind of breathing do they do? Yeah, they do pursed lip. What's their pH? Long-term COPD patient who's not sick. It's normal, 7.35, 7.45, because they've compensated, because they always have a high PaCO2. I've seen a PaCO2 of 120 on a patient who didn't want to be intubated. It was not a fun time in the MI that night. So if they compensate, what's their bicarb? Their PaCO2 is high because they're retaining PaCO2. Their pH is somewhere between 7.35 and 7.45. What's their bicarb? PaCO2 is an acid. Yeah. Bicarb's a base. If I have high acid to compensate for that, what happens to my base? I hear low and I hear up, and only one of those is correct. I have too much acid. How do I make it better? You need more base. Their PaCO2 will be high, or their bicarb will be high.
Yeah.
I've seen bicarbs at 40. If they're compensated, do I need to do anything? Oh my God, their PaCO2 is 55. Now they're compensated. That's where they live. Leave them alone. There's ABGs in action. So if that makes you really jittery, you should look at the ABG content, make sure you got it. It is more specific because when you name it, respiratory, metabolic, acidosis, alkalosis, the only pH is 7.4. We'll use the range when we do compensation. I know that's not how you learned it, but we are being more specific. Did somebody have a question? The answers on the test will not be respiratory, compensated respiratory acidosis. It's here's the gas, here's your patient, what do you need to do? Okay? Just naming it is a knowledge-based question. You gotta be able to apply it. All the questions I ask is about taking care of a patient and what you're gonna do. Okay? And they're not, I try to base it in reality, I don't make crazy things. Okay? So here's your concept map. Subcategories, those will play into specifically perfusion, cap refill, all of this, positive, negative. So be sure you look at that. There's your ABG bags. And age, things like that. Okay. Let's do a case study. Okay, so let's talk about cystic fibrosis.
This is so cool.
We have Sarah, she's a 16-year-old female with cystic fibrosis being admitted to the hospital due to worsening shortness of breath, increasing cough, frequent episodes of productive sputum over the past week. Let me read the last one. She also reports increased fatigue and decreased appetite. So somebody with cystic fibrosis, what's their problem? Oh, the screen's not on. Well, thank you. Yeah, they have thick mucus because cystic fibrosis affects any gland or organ that makes mucus. So they have a lot of mucus production. So guess what they spend their whole life doing? Yes, so they have an entire regime. So I did give you some, I usually try to give you videos that are short, but for this is a little bit longer about cystic fibrosis in the course of this. Back in the day when I was young or became a nurse 40 years ago, these people barely lived to adulthood and they are living longer. Could they get a lung transplant? Would that cure them? Why? We gave them a new lung. Come on, people. They still do have the gene and they will produce sputum, but it will certainly help. So it is familial. So they're going to have a lot of production, which means they spend a whole lot of time doing things like CPT, whether it's a vest. I think I have a little video of somebody wearing their vest. I've seen, from the time that they're babies, they're taking, so they're going to do airway clearance techniques, chest physiotherapy, PEP devices. There is a thing called pulmonary rehab. So do they have a lot of mucus? Yeah, because their entire problem is what? They have thick mucus, which affects more than respiratory. What else does it affect? So GI, what else? Yeah, GI pancreas, so that whole big thing. Reproduction. Okay, those are the biggies. If you haven't looked at this, you have pre-lecture recordings, which is where I really teach that content. Use your outline to take notes. You can make your own notes, but I've gotten you started. You just need more than that because we're going to have a class and put this into play and really learn with case studies. We're going to do a lot more active learning, and as I debrief, I'll do my teaching for that. What kind of medications do you think that they need to be taking? Well, they're not going to start with antibiotics. She may need them now, so you're not wrong, but let's think of a CF patient at home, bronchodilators. Okay, expectorants to move those things out.
Check it out.
Well, Siri wants to tell me about some weird crocodile. So, yes, pancreatic enzymes, because why? Yes, which ones in particular? ADE, the fat soluble ones. Okay, so they have a lot of nutritional deficits. So let's think of growth and development. I'm an adult nurse, but we all, we had last semester or semester before somebody was CF in the unit for, I don't know, at least a month. What are they going to look like? What's their growth and development? Yeah, underdeveloped. So we have to worry about things for growth and development. If I am a 16-year-old, say I'm a male, and everybody in my family is 6'4" or taller, are they going to be 6'4"? No. So what does that mean for them? How's that going to make them feel? We have to be touchy-feely and do the psych thing. I actually am into the psychosocial piece. It's really important. They're going to be small, right? No 16-year-old dude wants to be 5'4" if everybody in his family's 6'4". What else is important GI-wise? What do people with cystic fibrosis have that makes it really difficult? So think of, they are playing a team sport maybe, or maybe like I was a band kid, so they're in band and you go off somewhere. What do they have that can be really difficult when you're sharing a room with 3 other people? So they can either have diarrhea or constipation, but what's the important piece about? The steatheuria, the very foul smelling. So I relate this to, like I like to relate things to real things. I was in band, we would share a room with 3 other girls. So if I have cystic fibrosis and have horribly smelling poop, that's kind of embarrassing. Even if they're all my friends, that's still embarrassing. Like, we don't want to fart in front of people. So they have GI issues. So if they have problems, what do we do GI-wise? What do they need? I'm going to pick on you because you're eating. What do they need? You don't have to answer because there's food in your mouth, but. And what else? Pancreatic enzymes, because those are mucus producing glands that get stocked up. So when do they take their pancreatic enzymes? Before you eat. Is that just breakfast, lunch, dinner? No, it's all your snacks. So you got to do that for forever so that you have good nutrition. So that plays into why they may not be very big. Can they have children? Maybe, maybe not. It certainly would affect male glands and to be able to produce enough sperm. Do you have the capacity as a female to carry a baby? Sounds like conversations, if I have CF, I need to have with my OBGYN, right? And what's appropriate, especially like being diabetic. If I'm a type 1 diabetic and I've been diabetic since I'm 2, we know that that's going to give me an issue with maybe if you weren't diabetic, gestational diabetes. Those are conversations that you need to have. So I'm not saying you can't, but it will pose a problem. So they need to take their enzymes. So she is 16. I did that on purpose. Why? Let's think, how many of y'all have teenagers or had teenagers? My kids are grown. You're making a face back there. Why?
That's like girls' attitude. We're trying to figure out what they want.
Yeah.
Really cares that parents are everything.
Uh-huh.
So worry about what they're
Yeah. So our goal as parents is to raise children to go off on their own. Not that my daughter came home for 6 months. She's about to go back to Austin. It's how it is. And she's hated every moment being there. We're very much alike, but there you go. So part of normal growth and development is for them to be independent, maybe even say, I don't know that I believe or like the things that you do. That's fine. Once my daughter moved to Austin, we finally, she was like, oh, I understood. Because she's very much like me. And that makes it difficult. So I always use my own stories as an example. So they're trying to be their own. That is part of what they do. Which may also mean that they don't want to do what? Take care of their cystic fibrosis. So there's lots of psychosocial, but oh my God, my baby has this horrible disease. They've had it since they were little bitty. How might you know that they have cystic fibrosis? I remember this from nursing school when they were a baby. They're salty. I remember my OBGYN instructor talking about you would kiss the babies and they're really salty. That was a sign of CF. And I was like, oh my God, I still remember that. Because, PD's not my thing. But we see these as an adult. It's to raise them to be on their own. And that is part of what that Erickson stages when they're teenagers, that they need to take this on and we need to allow them to do that. So if I'm seeing this person coming in as at the clinic, and I need to ask all these questions, how might I ask? Think maybe more environment. How am I going to ask these questions? I'm 16. So if I'm seeing somebody with cystic fibrosis in the clinic and they're a teenager, part of what I need to assess is, are they taking care of their cystic fibrosis? So if their parents are in the room, what might the answer be? Oh, absolutely. Yeah, so what we may have to do is to find a way to get mom and dad out, or the mom or dad going, of course they do that. Of course they take their meds and do all their stuff. And they're not saying anything, which probably is code for, I'm not really doing it. That is kind of part of growth and development for an adolescent. We may need to get them by themselves and have that conversation. Do we go tell the mom, your kid's not doing their thing? Yeah, I do that because you go, that's crazy. That is between me and them, especially in teenager years. I can have those conversations one-on-one, and I need to do that. They need to feel comfortable with their healthcare provider or me as the bedside nurse. Because I've heard lots of crazy things as a bedside nurse, especially when people thought they were going to die. I had some confessions given, and I'm like, I do not need to know this stuff. So, yeah. So don't forget psychosocial. It is everything that we do. So do we kind of have two pieces to the psychosocial? Yeah, we have the parents. Do the parents need to allow a teenager to take care of their cystic fibrosis? Take all their meds, 100%. My goal is to grow my children up so they leave. They both kind of came back for a short period of time. It is what it is. Telling you, my daughter's not loved living back at home for 6 months. She's ready to go back to Austin. Got a great, gonna be set up quite well. So she's happy to get out. Her, the dog, the cat, and the gecko. Yes, we have a gecko. The easiest pet to take care of. Okay, history. Diagnosis cystic fibrosis at 2. Chronic cough, sputum production, wheezing, shortness of breath. Expected, unexpected. Normal versus abnormal. That's expected for her. That is not expected in people without cystic fibrosis or chronic illness. Frequent respiratory infections, including pneumonia, bronchitis, often needs antibiotic. Expected versus unexpected. It is kind of expected. Do we like it? No. Can we try to find ways to make sure that that doesn't happen? Yes. Make sense? Been using her bronchodilator, inhaler, and nebulizer with Saline Daily. High calorie, high protein diet with supplemental enzymes to aid digestion. Absolutely. Both parents are carriers. No family history of other chronic respiratory disease. What's the one thing Sarah should never do? Oh, absolutely. High school student or junior year. She's got a small group of friends, enjoys reading, and has a part-time job at a local cafe. How's that sound? Psychosocial wise. Sounds great. She lives at home with her parents and 2 younger siblings. She reports feeling stressed about schoolwork and managing her condition. Kind of expected. Do we have other questions? Say.
Like, what are you coping?
Yes, and are you more stressed? Are you just stressed because you're now sick? Maybe you're stressed because you're a junior, trying to figure out what to do. Now, is that of immediate concern? No, because what's of immediate concern? Airway, breathing, circulation, disability, neuro, those kinds of things. But we do holistic care that we do have to talk about that at some point in time. When we ask her history when she comes in, because we've got all those questions, how might we need to do that? Without her parents, right? We kind of talked about that. Because her answer in front of her mom and dad may be, I always do my treatments and I'm always taking my meds. Because I've had patients come in. I had a patient post bypass come in one time. This will play with PE that we're about to do. And I'm like, so like she's a week out. So guess what question I asked her? She's a PE. Shouldn't take both in her. Are you walking? Yeah. Or the post-cath patient who came in with restenosis after a stent. I'm like, were you taking your antiplatelets? Uh-huh. And then later she'd go, yeah, I really wouldn't walk. I know I wouldn't take my meds. I already knew that. I just needed you to tell me that. So do we need to make a safe environment for Sarah to tell us this? Yeah, absolutely. Which may be not with her parents around, and that's okay.
How would you ask the parents?
There may be reasons that you need to get them to go somewhere else. Or at 16, I don't know that they're going to stay the whole time. And you may just have to kind of figure it out while you're there if there's some undercurrent. She may do better with certain nurses. That it's easier to get these things out of. Not the priority now. The priority is her breathing, but we don't want to forget that. She's teen, she's fit for her age, she's got dyspnea, productive cough, yellow sputum, able to verbally answer questions with short sentences. So is that okay? It's not normal, but is it horrible? What would be worse? Yes, no, unable to do that because she's so short of breath. Do I need to ask all those questions when she's that short of breath? Absolutely not. I can do that paperwork later or get from family. She's fatigued, feeling more tired than usual. She's awake and alert, oriented. Last coma is 15. People's equal reactive to light. Some of you may want to do the A, that's for accommodation. You do need to know what accommodation means, and if you don't, you should leave it off. That would be falsifying documentation if you don't check accommodation. She's tachypnic, increased work of breathing. You all know what WOE is? Work of breathing. Wheezes, crackles noted in bilateral lower limbs. Use of accessory mouthfuls. With shallow breathing, productive cough, yellow-green sputum. Normal, expected, unexpected, abnormal. Would you expect her to have normal breath sounds, normal breathing? No. But she is more short of breath, increased work of breathing, which a normal finding for her, would that be increased sputum?
The color of the sputum is not.
The question was, would she have an increased sputum compared to you?
Oh, yes.
Yeah, that's a normal finding for cystic fibrosis. The color is the abnormal. Okay. See where I'm going with that? Expected versus unexpected, acute versus chronic, normal versus abnormal, and related to that condition. We talked about that. Heart's regular, fast, tachycardic. There's her vitals. Oh my gosh, she's 102. I know y'all, I heard y'all talked about this in PNC yesterday. Or maybe that was 3. I don't know. Heard about it. Just a heart rate of 102. Are you freaked out? It's not normal. No. If it were 120, would you be freaked out? Maybe. Do I need more information? Yes, you have to put it into what is going on, because maybe she just coughed a bunch of stuff up. She could be a little tachycardic, yes. So 102, I'm actually not terribly concerned. 120 might make me nervous, and I need to look at other things. So GI looks fine. Decreased appetite, bloating, constipation. So their GI goes from constipation to diarrhea. They have lots of GI issues, difficult to manage. That's hard for a 16-year-old. She's had weight loss, 4 pounds in a month. What do you think of that? That's a lot. Do I have a weight on her?
Yeah, one.
Yeah, she doesn't have a lot to weight. Steatorrhea. Voiding's okay, skin warm, dry. All right, vital signs. O2 sat 90. Do you like it? No. It's not 95. Is she ever gonna be 95? I don't know that she will, but 90 is not okay. If she were less than 90, I would be very concerned. COPD patient, do they have O2 sats that can be less than 90? Yes, but as a general rule, you would expect them to be 90 or higher unless you have a specific order that says it is okay for that O2 sat to be 88 and 89. You point your finger at me. We saw 86 one time. You don't just say, oh, because they have COPD, it's okay. Because if they get into trouble, you're in trouble because you missed a finding. You need a specific order from a provider. Hyperinflation of her lungs, consolidation and lower lows suggestive chronic infection. Sounds right. Got a sputum culture. She got Pseudomonas. What count? 12. What do you think of that? Hemoglobin's fine, platelets are fine, psychosocial. She's stressed from her chronic illness, impact on her social and academic life. She reports feeling isolated from her peers because of her frequent hospitalizations and missed school. Expected, unexpected. Or halfway in between. I think it's halfway in between. I think that she's going to have frequent illnesses, but they're more frequent. She's feeling more isolated, which becomes a problem because it seems like she's not managing her chronic illness as her chronic illness is giving her problems. I don't want to say she's not managing it. That might be a question I need to ask. Are you doing your things? This is hours of therapy that they have to do. That makes having a life really difficult. What sports? Can she do sports in school? Yeah. Which ones? How about anyone she wants?
Yeah.
Can we accommodate her? Yeah. Does the school probably know she has problems? They better, because she's going to have lots of meds. She's going to need an inhaler. Okay. You're the school nurse. You need to know about her. Yeah, 100%. She's going to be in your office and can't breathe. You'll have no idea how sick kids are in school. Also expresses concerns about her future health and feels anxious about not being able to lead a normal teenage life. Growth and development, Erickson stage, very common for a 16-year-old. Do we need to do that? Help her with psychosocial. What's her number one problem? Is it this? Somewhere I asked what her problems were. What concepts broke? Well, she has CF, so what's broke? Don't make this hard. Gas exchange. She has CF. What else is broke? So she has infection because of her CF. That would be unexpected. What else is broke? I heard nutrition, right? GI. And psychosocial, which is going to kill her first. Breathing. Okay. Psychosocial is important. I'm not a real touchy-feely nurse, but I talk about it a lot because it's important. And we need to, I've lived my life in an ICU and I've sat and held people's hands for a long time. Psychosocial is important. This is important. It's not important right now. We need to talk about it though. When she's better, I was the night nurse, and I cannot tell you how many great conversations I have with patients in the middle of the night who are concerned about things. Let's see. Her family is supportive, but her parents express difficulty managing her treatment regime, especially balancing school and therapy. Her siblings are young and unaware of the full extent. You think she feels like she's a burden to her parents, possibly? I want to ask if she's a burden to her parents. It's probably not an act. That's not a good thing. Might her parents be stressed because of her disease? Yes, a burden has a real negative connotation, and that's not where I want to go. It is difficult on the family. So is it just Sarah that we're taking care of? It's the family, which means she needs resources like what? Yeah, so she may need some, they have pulmonary rehab, she may need to go to that. Do we have financial issues? Is there, I don't know that there's like a camp for kids with cystic fibrosis, but if there is, let's send her, doesn't that sound like great? Where she can be around people who has the same diseases as hers and things like that. Maybe some, not really, y'all know what respite care is? Not really respite care, but maybe help for the family because there are younger siblings. How do you think those younger siblings feel? Depending on their age, but at some point it may be, well, it's always about Sarah and Sarah's sick and that's difficult. And so those are conversations that we have to have. So we may need social worker, caseworker, all of those kinds of things. She should have a pulmonologist, and they do have pulmonary rehab. Those would be good referrals, which is probably one of the many questions. Are you stretching? You have a question? Okay.
So, people that have cystic fibrosis, they have to be so.
So yes, because why? Because this is where this comes out of your book. When I wrote this up, I was like, I have feelings about that statement of if I have CF and you have CF, we shouldn't really be real close together. What? Risk for infection, but who else understands me but somebody else with CF? So can we take precautions? Yeah. So what do we wear? There we go. Yes. You got your mask on. I'm not going to ask why. I don't care. Wear a mask. Since COVID, if this is what you need to do, wear a mask. Think of places that you may not want to go that might have higher incidences of having sick people. When you go to the doctor, maybe you need to check in and wait in the car so you're not around a bunch of sick people, right? Yeah, all of those kinds of things. Coping. Difficult coping with chronic nature of her disease and physical limitations. She tends to isolate herself, avoid physical activities, social interactions, to manage her fatigue and self-confidence about her appearance. She may starting to develop a little bit of barrel chest. She's smaller than normal. She has these issues. She's 16. Is that a big deal? For her, that may be number one priority. Look, it's the page agency. He used to call me 3 times every day. I love spam. Referral to clinical psychologist for counseling was made. Sarah was encouraged to participate in a support group and connect with peers that understand her condition. Does that sound good? And her parents. Okay, let's go through some questions. Relevant clinical data for analyzing her signs and system history, diagnostic test. Expected findings, unexpected. So, what's her big problem? She has gas exchange problem. What else does she have? Yeah, it looks like she has an infection related to the fact that she's got lots of mucus not pulling it up. Because if I had to guess where infection is, probably in her lungs, right? We don't need to dream something up. It's probably sitting in her lungs. We also have a sputum. What is her other issues? GI. So what consult? Interdisciplinary team, interprofessional team. Yeah, dietitian. She needs her pancreatic enzymes. Is she taking them? Is she eating? What would be the best way to feed her? Or give her meals. We don't feed her. She's 16. Sorry. You know what I meant. Here's your tray, please eat it. Right, so she may need extra nutrition. So what might be helpful is, she doesn't really have a diet limitation. Let's give her what she wants. So she wants a milkshake, have one, have 3. I don't care. We'll put some insurance in it. She may do better with small, frequent meals, especially if she can't breathe. Because when you think of Maslow's hierarchy, breathing is right there. Eating is not. Nutrition is an issue. So she may need a dietitian. She probably has already talked to one. Not a bad idea to call one in. This is also where support groups can help. So what are we most concerned with for her? Does she need ABGs? I see somebody shaking their head yes. So let's think about drawing ABGs. It's a little bit invasive. If I don't do ABGs, can I get the same information a different way? And how? So if I get an ABG, what am I looking for? I go to people who can't breathe. The point of my respiratory system is gas exchange and oxygenation. Can I check oxygenation outside of an ABG? With a, there you go. If they don't need ABGs, we don't do ABGs. What would we expect our ABGs to be? Right now, respiratory acidosis, is she compensated, partially compensated, uncompensated? She's probably uncompensated because she's having an acute illness. She probably stays compensated, so what would her bicarb level be? It would be high, but I imagine her PaCO2 might be a little higher and her pH would be lower. Question, comment? So they hurt, they're invasive. If we can get the information off an O2 stat, that would be good enough. If they're acutely ill, which we'll talk about next week with respiratory distress, and I think I need to intubate, we probably want to do an ABG. Okay. The routine used to be if you were on the vent and intubated, we did ABGs every day. And no longer the case. Because can we get kind of the same data? Okay. You can always say, would you like an ABG? I'm concerned. They can say yes or no. And then you chart that you requested that and what the orders are. Because that's called covering your backside. So what's the priority for her? What does she need? So our problems, gas exchange, infection, are those two interrelated? Yeah, so we're gonna write them that way because we interrelate all this. So for those of you who wanted to interrelate and they made you write problems separately, welcome to level 4, we're gonna stick them together. Nutrition, psychosocial, isolation. I don't think knowledge deficit, anxiety maybe. Who else do we include in this plan of care? Yeah, her family. What's the SMART goals? Respiratory, give me a goal. Okay, so we need our O2 sat higher, right? So let's look to see what it was. Are we gonna get her to 95? I don't know. What was she, 90? So can we say 92, 93? I think that is a realistic goal. She might get to 95. Respiratory, what other goals?
She'll be able to.
Yeah, cough up more sputum, which means who's my best friend interdisciplinary person? Respiratory. Absolutely. She has an infection. What do we need? So we need some antibiotics. What's the goal for her infection? White blood cells come down, and I can think of another one off the top of my head. Well, where's her infection? In her lungs, so her sputum will thinner, would work with the CF, but certainly color change back to something more normal for the infection. But certainly I like WBCs because that's a good old number.
You say normal, you know, like
Clear white is typically normal. Hers got yellow green, not good. Certainly, will she produce sputum?
Yes.
Yes, that is a normal finding. She will have a lot of sputum. Do we need to do all of these things to help her? Yes. What would be important about, let's think respiratory therapy kind of stuff. When the respiratory therapist comes in, what might they need to do? It's my patient and all these other people come see them. That's how I look at this team thing. So she'll need CPT and all that, but what's real important to ask? What's her baseline and how's she doing it? So, sometimes we have the little do-do-do. She might have a vest. I think I've got a little video of a vest. She knows what she does this all the time, right? can we not allow her, if she's physically capable and has enough gas exchange, to do some of that and to tell us how she does it? When does she need to take her bronchodilator? Why?
You don't say give any.
To open up the airway so that she can cough it out, because that's the point of CPT. I remember in nursing school learning about postural drainage, and you have to put them like head down and do this. I still do this if I turn a patient on. We do a little CPT. We have machines now. We used to do it by hand. Yeah. What is she doing? Should the respiratory therapist assess what she's doing at home? Yeah. One question might be real important to ask. Is she doing this? Because in front of her parents, her answer may be yes, and she's really not. Can't tell you how many times people have said that. That later go, oh yeah, like the DVT lady. It's like, were you walking after your bypass? Oh yeah. And then like an hour later, she's like, not really. Well, she had a PE, already knew that. She had DVT. I didn't say that to her, but I'm like, okay. And then she's like, yeah, you know. So let's talk about why that's really important. I always learned lots of things working weekend nights. Significant problem, SMART goal, O2 sat, increase in sputum to be less. We need to do diet. Psychosocial as well. We always do psychosocial. What is she at risk for? I like a good risk for. Anybody with CF is at risk for infection. Check. That's actual, not potential. What other potential complications does she have? She does have malnutrition. She's probably a little bit borderline. Might we check those labs? Yes, I know Becky's really into all that. And we were talking about, that's great there. And then everybody in the unit has a nutrition issue. And let's talk about the bigger things is how I look at it. But I'm used to working with really acutely ill patients in an ICU. Psychosocial? Yeah. What about school? The more she's sick, the harder it is going to be to catch up. That can compound. She's a junior. She may want to go to college. Can she go off to college? Yeah, 100%. She just needs to take her stuff. Probably, let the clinic know, hey, I'm here. I have a chronic illness. She can take care of her stuff. Let her roommate know. Because is she going to cough? Yeah, she needs to cough. She needs to move that mucus. So we're going to make SMART goals that are realistic. What are we going to do? Meds? One med that she needs. Yeah, she needs a bronchodilator. I need to find out what she takes and probably restart it. But what med does she need? She needs pancreatic enzymes, but what's more important? Her antibiotic. So when you do your CJN, you're going to write things like she's on vancomycin, which is an antibiotic, and then we're moving on because we're doing them while we're in clinical, so we're moving on. Complications. I think we've talked about that. Discharge education. She knows she's had cystic fibrosis. She's 16. No. Social worker still needs to see her. Talk about, is she doing it? Are there other resources? What resource would be really good for her? She's 16 with a chronic illness. Yeah, so incorporate. Let's find her one. She probably knows kids because they're in the hospital together. Okay. How do you think she feels? Can she lead a normal life? She can. It is not normal for other people because she has a chronic illness, but our goal is to help her to be as normal and she's 16, she needs to take over her care. Because if she's got parents who are like, oh my gosh, I'm going to do everything for her, does that work at 16? Absolutely not. She needs to take over that. Team members, I think we've talked about goals. Yes, don't die. O2 sat's better. Y count comes down. Sputum's better. Something nutritional, those don't tend to just get better overnight, but that is a problem we need to work that out. All right, cystic fibrosis makes sense. Do we have any questions? You've got some farm notes. There's under lifespan considerations, there's no older adults. Why? They don't live that long, but they are living much longer than they used to. So at the end of all your outlines, you have clinical judgment questions. I would highly recommend, and Z will agree, that you should fill those out. They're kind of nursing process, clinical judgment questions, working through all of these. You do have the nursing process in your book. They're okay. I always think of other problems. I just think of it slightly different than what your book has. So that is a good tool for learning. Case study is the best way to study. This is a patient and how do you take care of it? Okay. I don't know if I was recording. Sure thought I clicked it. All right, let's do.
Is it the case studies we have to turn in every day?
Nope.
What is it that we turn?
In class activity.
That's one of us.
No, this is the case study.
Same thing.
Yes. Yeah, was there not is that the tutoring contract? Is there not a print name? Okay, yeah, we gotta check you off. You have to turn them all in. So, yeah, go check them and get your name. All right, let's do.
Yeah, because we got that.
I can't talk loud enough for y'all.
Yeah.
Let's not strain my voice. All right, so we have Frank Salazar is a 58-year-old male witness to the emergency department with dyspnea, productive cough, with a clear sputum and sharp chest pain. Symptoms started 2 days ago. He denies any injury or trauma. So what's wrong with him? Can we tell yet? What's broke on him? Yeah, it's a gas exchange problem. So even with cystic fibrosis, what is the general things we do for gas exchange? We've already talked about raise head of the bed, right? Give them some oxygen. If they're having signs of distress, the goal for our O2 sat would be 95, with the exception of people with chronic illnesses like COPD, cystic fibrosis. I would expect all of them to be greater than 90. If they are not maintaining that, I would want a provider order that says it is okay to have an O2 sat of 88, because if something goes wrong, you're going to be in trouble. So cover your backside. Okay. What else do we do? Put oxygen on them. What do we assess? Lung sounds. Okay, good. Anterior, posterior. Do a good job. What else? Why would it cardiovascular? That's cardiac. That's my jam. This is respiratory. Because it's cardiac, it's respiratory, and a lot of time it's cardiac respiratory. So you're not wrong. I just want you to think about things like that. Yeah.
I can
So,
try to explain it to you.
yeah, that's okay. I'll just, questions I always ask. Sometimes it's respiratory. You've called it respiratory forever. We are starting to put things, heart failure is both. I'll show you how we put it all together. So if you've been wanting to put it all together, welcome to the semester that you can do that. Students are like, I've been trying to put this together since level 1, and they wouldn't let me. I'm like, please, let's put it together. If you haven't, let's work on putting things together. Okay? Because if I can't breathe. Do you have other questions for him? What history would be important to know about?
What was it?
Well, he has a respiratory problem, so those aren't wrong. I am thinking of one thing.
What was he doing when he had this chest pain?
Okay. History. Yes, do smoke. Surgery, yes, we'll get there, but do smoke, that's a respiratory thing. Okay. Is it just smoking now? I think we have to adapt what we ask. Do you vape? Oh, but you're less than 21, you don't vape.
Yeah.
Y'all laugh at me. You're less than 21, you couldn't possibly drink. I will tell you some of the worst liver failure I've ever seen in people who died were 19, 20, 21, 22, and honest to goodness, the worst one was 32. So just because they may not be of legal age doesn't mean they're not doing it. And is it just cigarettes? So it's vaping and it is marijuana now. That's not legal in Texas. Why on earth would we ever ask that? Because it isn't legal in New Mexico and Colorado, and we know people do illicit drugs. So there you go. Do I judge people for that? Y'all are sassy. In your heads, you might judge them, not out of your mouth. Do I care that my patient maybe is homeless and can't pay? Do I care that they're transgender or whatever? I might care if they're a jerk to me or to their family, but my job's to take care of you. Like, I hate it when they're like, oh, you have a VIP. I don't care. I don't care if you're homeless. My job's to take care of you. I need to see what resources you have. Don't tell me your husband's a doctor or your wife's a lawyer or any of that. I don't care. My goal is to take care of you. I don't care. Just don't be a jerk. 90 kilos, 72 inches, blood pressure looks fine, heart rate's a little faster, respiratory rate's fast, Tim's fine, 027. Oh, not really good. Dysrhythmia is your first quiz, so welcome to some strips. What is this? How do you know it's not a stack? So there should be 1 P weight before every QRS. Normal PR is 0.12 to 0.20. QRS is 0.04 to 0.10, which is what I teach. You have an EKG book. You get it because it has a ton of strips in there. You do need them. You also have a dysrhythmia guide that I dug up from 1,000 years ago when Dr. Gunn used to teach advanced concepts with me in this room. And how do we know it's sinus attack? I mean, yeah, I gave your heart rate, but there's an easier way to tell. So you look for a 6-second strip. Hash mark to hash mark is 3 seconds. 3 seconds, you count the ROAs between, which means I don't count this one and I don't count that one. 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 10, 20, right about 130. Did I count correctly? You're looking at me funny. 118. That in itself, is that concerning?
Yes.
Is one vital sign concerning? Maybe he just coughed. Would his heart rate be fast? Would his respiratory rate be fast? Yes, but I need to take all of those other things into consideration to paint that bigger picture. Sometimes it is just one thing. Well nourished, development, mild dyspnea, skin's more dry, cyanosis, white line oriented, clear bilaterally, diminished right lower low, productive cough with clear speedo. Is that normal? Diminished? No. Coughing up, but it's clear. Okay, not sure why. Don't know that I care quite yet. Regular rate rhythm, no murmurs or gallops. Bowel sounds are fine. Had a BM yesterday. Do I care? Anybody over 70? Are they all about their bowels? Yeah, 100% they are. Okay. Voids, no extremities, no over swelling. Left half is warm pink with mild tenderness. Normal, not normal. Let's read his past medical history. He takes amlodipine, valsartan, and metformin. So what's wrong?
Hypertension.
Yeah, hypertension and diabetes. Recent knee surgery. He's short of breath. Huh. What's going on? So pulmonary embolism, which came from where? So deep vein thrombosis or venous thromboembolism, whatever you learned from his leg because he had surgery. So what question might you ask? Yeah, I literally had a post bypass one time who I did say, were you walking afterwards? And she said yes. And then later she's like, no, not really. I'm like, well, I already knew that. Did you ever PE? So it broke off, came up to her heart, went through what side of her heart? the right atrium to the right ventricle through the pulmonary artery into her lungs in his lungs where it stopped. So PEs are really two different problems. What are they? Gas exchange and perfusion. Okay, works under both. I do think this actually is this chapter 16? Yeah, so that's my favorite. That's the perfusion chapter. I'm a cardiac nurse. I like perfusion. It's both. Okay. Smokes 1 pack per day. Says he only smokes a couple a day. Is that going to help anything? Not really. So what's relevant and irrelevant information? Key pieces of information. What do you think's wrong? Yeah, he's got a PE. I will tell you, I've never met a PE I've liked. I've had more patients just spontaneously die from PEs than probably anything. And I worked at cardiac ICU and had acute MICE. PEs are awful. What makes it aggressive? Okay, what are all the other risk factors? Surgery because he's immobile. So what should he have been doing? What do we do post knee surgery? I need to know this. I'm going to have you. They need to ambulate. We put them in the CPM machines. That's really for the joint. What else might we put on them? Yeah, so TED hose, maybe thigh highs, maybe knee highs. Is it important to tell people why you got to get up and walk? Yeah, 100% it is. Because it doesn't feel good. I don't want to do it. It hurts. Blah, 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 blah. Or I can be sick at home and everybody will bring me things. We don't want to scare our patients, but they do need to know that there are some consequences with this. What are the other risk factors for PE? Yeah. Immobility, things like traveling. Okay, this is where young people who travel, fly, sit for a long period of time. This is why when we drive somewhere, like my daughter's moving to Austin, we should stop every couple of hours. We should probably she literally makes one stop. Do what? Yeah, but that's not good. Let's see, which doctor was it that I said that he knew somebody who was young, drove from Dallas to Amarillo and got a giant DVT and a PE and tried to die. And orthopedic surgeon in town, and said when his wife drives to Lubbock, he has her take what? And aspirin. Yeah. Yeah, baby aspirin. When I've flown overseas, those kind of things, you can get compression socks, take a baby aspirin. What else can you just generally do? Hydrate. Yeah, you can hydrate. A colleague here, her dad was a farmer and got a big DVT and PE and landed in the ICU because he was out harvesting his crop on the tractor for 12 to 14 hours. So I've never met a PE other than mine. Do we have other questions? Did you walk? When did this start? He's like, oh man, let's see if I can get my leg up here. That really hurts. You want him doing that? Does that make you go, yeah, because if that clot in that vein goes, which direction does it go? What if it was a clot in my artery? Yeah, it is going to go somewhere. Which direction? Yeah, to my foot. And my foot would look like what if I don't have arterial flow? Cold, pale, pulseless. Venous clot is, so arterial clot is blood not getting there. Right. So pale from whatever skin color you started with to wherever you're at now. Venous is warm, pink, red, because the blood is stays there and it's not moving up. Okay. So we decided he has what? A PE. So what are we going to do for him? So I gave you some recognized cues, analyzed cues. We're through here. What's most important? He's got a clot in his lung. Is he? Yeah, he's going to try to die, right? So what am I going to give him? Are we gonna do anticoagulation or thrombolytic? Thrombolytic's clot buster. Could we? Yes. Can we take them to IR and go suck the clot out? 100%, and I've seen that. Saddle PEs, they come down and they're like this. They're awful. But he needs some kind of anticoagulation. What do you think we use most often now? We do T and K if it's a clot buster, which we'll talk about more with neuro. Can't use for MI. Let's just put it over neurally where we see it. We do enoxaparin, but there's something else. Let's think about what's the easiest thing for them to go home and manage. Apixaban, Eliquis. It gets therapeutic quickly. It becomes untherapeutic quickly, as opposed to if we start heparin. It is what I put in here. We may see heparin, then they're going to be on what long term, because you don't go home on heparin. Usually, if you're on heparin, you're on warfarin. And what do you have to do every month if you're on warfarin?
I know the last one.
Yeah, and a therapeutic INR for warfarin would be what? 2 to 3, because normal INR is 1. But I will say, for the most part, we'll put everybody on Apixaban. It's a great drug. Don't have to get your labs checked. It's very expensive. Warfarin is not going to go away. What's our goals? Got a gas exchange problem. Give me a goal. Yeah, O2 sat greater than 95. No indication of COPD or anything. Let's make him 95. Does he have chest pain?
Yes.
Sharp chest pain. When do you think it hurts?
It's over.
Probably when he takes a deep breath. Let's see. Generate solutions, make those go. Psychosocial, think he's a little nervous. Think his family might be a little nervous. So interactions, we'll go through that. So we've got some orders. CBC, basic metabolic panel, coag, ABGs on a mission. Does it really need ABGs? Yeah, I threw them in there. So if they didn't order it, I don't know that I would be that concerned. If they want it, okay. 12 EKG, why? Why does his EKG rhythm matter? Okay. Well, what rhythm do you know? What's the normal rhythm? Sinus. What rhythm leads to clotting? Atrial fib. And people have intermittent atrial fib. Make it a little nervous. You need to start looking at dysrhythmia content now. If you wait till the 7 days that thing's open, you're going to have a hard time. So I have included it for you, make you a little nervous. IV normal family at 50, vitals Q4, bed rest with back and privileges, chest x-ray, CT angio, which they're going to do to go look at it, venous Doppler of the legs. So you could prioritize that and say why things are most important. What's probably your most important thing out there? Yeah, probably put some OT on, start an IV, don't code on me. Why does he have a calorie control diet? Yeah, because he's diabetic. What's the D-dimer going to tell me? If there's a clot. All right, let's look at his labs. Let's look at this. Those look fine. D-dimer's high. So who does gas? Why is this PaCO2 34? What's his respiratory rate? 34. So he's blowing off his PaCO2 because he's tachypneic. Totally EKG, can do an X-ray, CT angio. Later in your shift, visibly anxious, sitting up in bed in distress, tachypnic, use of accessory muscles, states he's got sharp chest pain, 7 of 10 on pain scale. Doesn't radiate, increases with his breathing, he's coughing up blood to speed. What do you do?
Follow code.
No, he's not almost dying. What are you gonna call it? Call an RRT rapid response. Call a code when they don't have a pulse. Or just about to code. I remember when RRTs came out, that says my patient's in distress, I need to do something. Okay, so we call an RRT because he's got all the symptoms, he's slightly agitated, he's kind of confused, concerning. Yeah, he doesn't have good gas exchange, he's got crackles, increased work of breathing, got some PVCs. We're starting him on heparin. With titration, both with 8 units per kilo of heparin, started at 18 units per kilo per hour. So there's your free dosage and solution to do. Titrate. What labs do we give for heparin? BTT. If he's on warfarin, we would get a INR. Okay, give you a little dosage thing. Vital signs, O2 sats 96, heart rate, blood pressure's better. Do you risk for a stroke? One. Where's this clot? Where was the origination of his clot? And that traveled and got stuck in his lungs. Probably not coming out of his lungs, going somewhere else. Does the DVT lead to a stroke? It's my favorite question. I need to know blood flow through the heart. Goes my legs, comes back venous, it gets stuck where? In your lungs. It's not coming off the right side. What's the number one reason people have strokes? What's the rhythm? If the clot's coming off the left. Blood flow through the heart. All right, he carries on a little bit. Stable discharge from medication. What do you think he's gonna go home on? What medication? What medication? Some kind of anticoagulation. What are we gonna teach him about? Absolutely. Okay, questions on that content?